It's been an incredible honor to serve as the president of the AAES this year. It's a chance to reflect back on the time spent in the AAES, what I consider my professional home, and all that this has meant to me, and the opportunities that have been given to me by associating with people like you all. It's customary at times like this to reflect on mentors that we've had over the years. I think out of all the people and places that Barry just pointed out, probably one of the most important professional things that happened was the opportunity to train at UCSF with some of the people you see here on the slide, including Orlo Clark, obviously, who was a very prominent leader there at the time, but also led by Haile DeBass and with Larry Way and the others you see here on the slide, who've gone on to leadership in their own way in American surgery. UCSF wasn't just the faculty, though. It was also the colleagues that we had, and this is my class of chief residents at UCSF, and I put them up just as kind of a marker for all the people who were there at the time, and it's many people who were in the room, including Quan Du and Alan Sipperstein and others of you who came through at various periods to train with Orlo and spend time in the lab, and it meant a lot to have those folks around. You may recognize some of the people who are on this slide. Five out of the six of us have gone on to very conventional academic careers. Diana Farmer is the chair at UC Davis. Hobart Harris is the chief of general surgery at UCSF. Mike Longacre is the chief of surgical research at Stanford. And Marco Patti is a professor of surgery at the University of Chicago. We're all full professors, members of the American Surgical, very safe, conventional approaches to things. The guy on the bottom left is Bob Kroschelt. Bob has spent a career in rural surgery. He spent a lot of his career in West Virginia and rural Alaska as a flight surgeon. He's currently in eastern Montana in a two-person practice. And out of the six of us, I'd say Bob may have had the most direct impact on patients who wouldn't have had somebody else to take care of them if he weren't there. So I greatly respect his choices over the years. I had great mentors as a junior faculty member and along the way as well at WashU and in St. Louis as well as in Ann Arbor. And I advise you all to pick your partners very carefully because they affect our day-to-day lives, they affect how we learn things, and we all have to continue to learn from them. And that's continued to be true in Boston with my partners at BU School of Medicine, Bob Beasley and Dave McEnany pictured here. It's really a wonderful group. I should probably show a picture of the entire department. More importantly than any of that, though, has been my real family. And you've seen some photographs of them today. We love Halloween. I love seeing all the old Halloween photographs. I was very lucky to have met Faith in college when we were resident assistants in the same dormitory. And we've now been together for 35 years and married for 32 of them as of next month. And so it's been obviously the luckiest thing that's happened in my life. And the greatest project that we've undertaken has been to build our family. We're having a wonderful weekend here. We don't always get the chance to be together now that the kids are bigger and off doing their own things. And so it's been great to all be together here the last few days. What I'm going to talk about over the next few minutes is what I know about. And I have spent a lot of time, as you heard, in surgical education. And so I'm going to talk about how I think of general surgery education and endocrine surgery education and building careers in endocrine surgery. There are a couple of caveats to that. I recognize that not everybody in the room is a general surgeon or even a surgeon. And so I suspect that some of the things that I say and some of these principles apply in endocrinology or otolaryngology or pathology, but you'll have to bear with me. I don't know enough about those fields to comment very well about them. I'm also going to focus on the clinical parts of our careers and not talk about the research or teaching or administrative parts, which are very important to all of us. Endocrine surgery is a relatively recent area of focus within general surgery. The AAES and the IAES are less than 4 decades old. They started out as gathering places for surgeons, mostly general surgeons, who were interested in diseases of the thyroid, parathyroid, pancreas, and adrenal glands. There were forerunners that surgeons belonged to, including the American Thyroid Association and the Endocrine Society, but the AAES really allowed the concept of a surgeon who is expert and interested in endocrine diseases to crystallize and to become a separate specialty. Over time, the AAES has developed into a robust specialty society. We were established to organize an annual meeting of the members, but we've now diversified into accrediting training programs, publishing position statements and guidelines like what we heard about from Dr. Carty yesterday, providing seed funding for research, and also maintaining a quality improvement data platform. Many of our members have developed clinical skills and reputations that have led to practices exclusively limited to endocrine surgery. They've advanced our field not only in our ability to care for patients and our reputation as a professional society, but also in how we think of ourselves. However, with this evolution of highly specialized surgeons, I believe there are some unintended and important consequences not only for endocrine surgery, but also in other similar areas of subspecialization within general surgery. And this morning I'd like to explore our understanding of a satisfying career in surgery and how one goes about generating that and protecting that. And to make some recommendations for how knowing the components of career satisfaction should inform our plans for surgery training, initial positions that we offer junior attending surgeons, and the things that the AAES should offer as a professional group to support that career satisfaction. I'm going to speak from my experience as a general surgery program director, as an endocrine surgery fellowship director, as head of an academic general surgery group, and as chair of an academic department. Like many in the room, I've had hundreds of discussions with medical students, residents, fellows, and junior faculty about how to plan their careers in surgery. I've served as part of the teams that have shaped the standard curriculum for general surgery through the APDS and other national organizations. I've worked through the AAES on the fellowship training plans for endocrine surgery, and I'm currently serving on the Surgical Oncology Board of the American Board of Surgery. However, the things I'm going to talk about here this morning are my opinions and shouldn't be traced back to St. Louis or to Frank Lewis and anything to do with the board. Satisfaction with one's own profession is a very complicated issue, and the RAND Corporation has recently completed a sort of white paper on what is associated with physician and surgeon satisfaction in their careers. Factors like income compared to expectations, the level of control of one's time, the opportunity for collegial connections, and a personal contribution to group success are all important. However, there are two primary aspects, and those are to do work that is important to other people, and also to be very good at what one does. You need to be highly skilled. I was kind of going for booze there. Does anybody recognize this guy? Our goal in preparing people for those satisfying professional careers as surgeons should be to ensure that they have the training to skillfully perform work that will be important to others throughout a full career. So that preparation that we do during surgery residency and fellowship has to last for 35 years on average. Now, 1 year of endocrine surgery fellowship can't generate all of the skills and knowledge you need to have that satisfaction, but I believe that year can be an important capstone on a foundation of general surgery training. And I'd like to describe some of the things that I think we should do. The first principle of career satisfaction for physicians and surgeons is to have work to do that is important to others. So what do we know about the surgeons that the United States will need over the coming decades? The American Association of Medical Colleges has very recently released a report that they commissioned from IHS Incorporated to project physician supply and demand through 2025. It's a very complex analysis and includes effects that will change demand for physician and surgeon services over that time period, including population growth, population aging, and increased healthcare accessibility due to the Affordable Care Act. There are also considerations of changes in the provider supply, including the demographics of the physician workforce, millennials' expectations of work schedules and retirement age, as well as both the growth of concierge medical practices and non-physician practitioners in primary care. The result of this is that there will be a substantial increase in the need for general surgery services and general surgeons over the next 10 years. Part of that is because, unlike primary care, there are no current models of care in which non-physician practitioners can substitute for our core work. In 2013, where this study starts, there are about 155,300 surgeons in the United States. And the areas that are included as surgical specialties are shown here on this slide. You can see it includes general surgery, but also several other specialties. In 2025, the supply of surgeons will be roughly the same. You can see we started about 155,000 surgeons on the slide here, and by 2025 we sort of crept up to 160,000. I've chosen to show on the slide some of the most optimistic numbers in terms of the numbers of surgeons. These are the, if we delay retirement of surgeons by an average of 2 years, we can get up a little bit to 160,000. You can see the surgeon demand, including those demographic changes and accessibility changes, far outstrips the supply, leading by 2025 to a shortage of between 23,000 and 32,000 surgeons in the U.S., about a 15 to 20% deficit. The gap is not evenly distributed, though. The gap is in general surgery, OBGYN, and ophthalmology. Some of the other surgical specialties actually have a decrease in their need because managed care payment scenarios and other alternative payment models are predicted to decrease demand in some surgical specialties. This is because general surgeons provide necessary care, not discretionary care, and even payment scenarios designed to limit access to some types of care will not decrease the need for our services because of their nature. So how should we prepare surgeons to fill this demand and to do so in a career-satisfying way? Society needs broadly competent practitioners prepared to do indispensable work, and the surgeons who fill these roles will be in demand and will have the opportunity for that satisfying career in their institutions and in their communities. To prepare for this career, surgeons should aspire to general proficiency, especially earlier in their careers, and not become so differentiated, if you will, that changes in diseases or treatments can marginalize them from being crucial to others. One need only compare the relative demand for cardiac surgeons and vascular surgeons today to understand the career risk to becoming expert in a specific technique, no matter how delicate that technique is. We must remain directly involved in our patients and the care of their diseases, not just the procedures. And that will make us capable of incorporating new managements and technologies into the care of those patients and diseases. In the next decade and beyond, the expert general surgeon will remain important to others. The second principle of career satisfaction is the ability to perform one's work well. In order to achieve this over a career, one must not only learn today's problems and how to take care of them, but also gain competence with the surgical principles that will allow the incorporation of future advances. With a foundation like this, as medicine advances, the surgeon can employ various aspects of their proficiency over their time in the field. So does medicine really change that much? If I look around the room, I see myself and my colleagues who either participated in or witnessed the development of laparoscopic surgery, the near total disappearance of complicated peptic ulcer disease, and image-guided interventions of all sorts that have all appeared over the span of a couple of short decades. My co-chief residents and I memorized the details of those randomized trials of prophylactic node dissection for melanoma, only to have sentinel lymph node biopsy render all of that irrelevant within a few short years. Throughout all those changes, we were able to remain competent because we'd mastered some fundamentals of patient care and maintaining some basic broad competency in addition to our specialty. As changes have appeared, we've been capable of continuing our careers because of the knowledge of the patients, their diseases, and the evolving technical interventions that we can employ. The training that we provide must be designed for the trainee. We have to recognize that building skills durable for a 35-year career requires that we teach the fundamental principles of diagnosis, surgical techniques, and surgical physiology, like wound healing, that are going to underpin whatever advances occur during their careers. I think that there are important parallels between general surgery residency and the undergraduate education that we all pursued in college. Armed with a college degree, a graduate is prepared to do many things and equipped to learn to do many others. They can pursue further study in a specific area, or they can be employed with a basic set of skills, honing those existing tools and gaining expertise through their experience. However, the thought processes that they gathered during that undergraduate training remain relevant because their basic education doesn't change. Learning to those basic tools don't change over their career. That has led to a prepared and informed graduate that can perform over an entire career. And general surgery residency should be the same way. We have to provide durable knowledge to form that foundation for a 35-year career. Designing training for the trainee, then, would lead us to encourage broad competency, especially early on, and prepare graduates for the spectrum of potential futures that they might face. Conversely, the relationship between surgical volume and patient outcomes is well established. To that end, our plans have to balance the demands for that widely exposed resident to the surgical skills and management plans of the moment with a simultaneous requirement for a narrowly focused expertise of the subspecialist. The ongoing trials for general surgery residency address this balance in different ways, and I'd like to talk a little bit about those for a few minutes. The standard general surgery training program includes 60 months of clinical work. It includes training in 10 core areas that are shown here on the slide as defined by the American Board of Surgery, and you'll see that endocrine surgery is one of those 10 core areas of general surgery. The requirements and the curriculum are available to generate a solid fund of knowledge and operative experience and specialty exposure during that 60 months of general surgery training. We now have milestones of professional proficiencies that we need to meet or expect the residents to meet, and we've poured effort into understanding how to fulfill those mandates within the ACGME duty hour requirements. And you can see on this slide the traditional program is in the top line there, and it's the 60 months of training. Most graduates then go on to pursue further formal training after the 60 months, many of them are within those 10 core areas, and you can see the red bar here is that additional 12 months of fellowship training that has become quite common. They have at least basic skills in those 10 core areas from their general surgery residency, but 80% of our residents choose to go on to get further training after general surgery. 20% of them go into practice, presumably like that liberal arts graduate who goes on to get a job and hone their skills that way. There are several proposals to change general surgery residency, and they seek to address concerns regarding the duration and applicability of some components to the trainee's eventual practice. The current methods that are in trial maintain the preparation across the spectrum of general surgery, but either emphasize some aspect during the last 24 months or allow an early beginning to fellowship, usually vascular surgery, that then extends beyond the 60 months. The Flexibility in Surgical Training Initiative emphasizes areas within the 60 months that are part of general surgery. This allows the program to focus both the trainee's effort and the program's effort on the area of the trainee's interest, rather than requiring that each program graduate have essentially the same experience as the ACGME has done in the past. The Early Specialization Program, by contrast, includes 48 months of general surgery training, followed by 24 months of specialty training in usually vascular surgery, but also can be cardiac surgery. And both of those plans lead to certification in general surgery as well as the specialty. Most of those patients in the Flexibility and Surgical Training Program also go on to fellowship, which you can see denoted here as that final 12 months after completing residency. A more recently developed approach is the Transition to Practice Fellowship, developed by the American College of Surgeons. The goal of this is to provide formal mentorship in an initial post-residency year that accelerates the adaptation of the newly minted surgeon to independent practice. These are the principles of the Transition to Practice program as outlined by the American College of Surgeons. You can see it's to provide some additional autonomy in a supervised fashion with mentorship and understanding of the different aspects of independent practice. Many of us recognize this as things that we learned in our first post-residency position. As Lee Newmeyer has said, the most important year of her residency was the first year after she finished. Those of us who were either lucky or smart enough to take a well-organized job had this experience, but we didn't really have a name for it then. The college has now put a name on it. This is conceived as a one-year experience with enhanced autonomy but senior mentoring, and includes practice management skills that are often neither taught nor learned during residency. Some have called this a fellowship in general surgery. It's really a guided transition to independent practice, and it typically emphasizes general surgery practice, often abdominal and hernia surgery. So how can we incorporate these models in endocrine surgery as an example of a subspecialty within general surgery? I believe that we should adjust the fellowships that we offer in endocrine surgery to emulate that transition to practice model. And you can see that I have denoted this on the slide by, I've now shut off my machine here. Luckily, I have my son print this out, so I don't have to depend on the iPad. I've denoted this on the slide by showing the post-residency fellowship as a hatched bar that includes also the transition to practice models. I think that we can adjust the fellowships to emulate that transition to practice models. And I think that although fellowships have to provide that intensive training in endocrine surgery, in our example, in order to generate people who have those special skills, and that can help us to provide that second principle of career satisfaction, that one's very adept at one's craft. However, we should also not limit our graduates' horizon to the belief that an unalloyed endocrine surgery practice is the ultimate or even the optimal goal of us as trainers. A satisfying career for 3.5 decades and to provide the country with the surgeons it needs should be our goal. We can only reliably prepare young surgeons to have the competencies both broad and focused and capable of work to serve his or her community if we do this well. I also believe that all new endocrine surgery fellowship graduates and other surgery subspecialty fellowship graduates should maintain their competence in specific areas of the core general surgery aspects, including acute and non-acute management of the abdomen and its contents, and that this experience should be included in our subspecialty fellowships. The endocrine surgery fellowship transition to practice paradigm can then also extend into the first post-training position to include mentor relationships with a new attending. One of the challenges of this is the fact that some of our best fellowship opportunities are with senior surgeons whose practice is very highly specialized and circumscribed. That's what allows those specialists to provide that tremendous fellowship experience. The AAES fellowship accreditation requirements also emphasize the endocrine-specific aspects. To counter this, I would recommend that we change our requirements. I think we should broaden them to say that the optimal endocrine surgery fellowship provides both the endocrine and endocrine surgery experience and the transition to practice experience, including those non-endocrine general surgery portions. Now, our graduates may naturally wish to mimic or emulate their mentors and the focused practice, but we should help them to avoid the trap that leads many to believe that a high level of specialization ought to be the early goal in a surgeon's career. The jobs that we create and offer must also speak to this. They must meet the needs of society and the new partner. I think we do a disservice to our fellows when we create the illusion that focused training in a specific area of general surgery is going to lead our graduates to a clinical position that's limited to that area when they finish. Besides being an illusion, because not all those jobs exist, I think it hampers the young surgeon, constraining their development as a broadly competent practitioner. That can only happen with practice. At the Endocrine Surgery University earlier in the meeting, we went around the room and talked about the first jobs of many of us in the room, and they all involved general surgery practice, and that was where we developed some of our practice skills. And I think our trainees need to know that and recognize that that should be their first job. In order to facilitate a 35-year career as a surgeon, the young attending should develop broad competency in more than one of the 10 core areas. I believe that all surgeons should hone their skills in the area on the left side of the slide there, in the skin and soft tissue surgery, general abdominal surgery, and emergency care early in their career. That will allow them to adjust to changes in the practice of surgery, which are inevitably going to happen during their time as they've happened in ours. Terminal differentiation into a specialist within a limited area of practice at the age of 35 may lead a surgeon to a career position with diminishing prospects and an unsettled future at age 55. Many of our most admired senior surgeons have developed these practices over decades. Other facets of general surgery have been squeezed out by endocrine surgery referrals. However, they started out as competent practitioners in general surgery. This development of a more focused practice is common but not a universal process and has little risk for the senior surgeon. If something changed, they could fall back on their broader competency that they developed early on, should their personal or professional interest evolve. Finally, I believe that this understanding should inform how we shape our American Association of Endocrine Surgeons and what we offer. Our archetypal member could be a competent surgeon who's valued in their community, whether that's a regional hospital, a multidisciplinary group, an academic medical center, or a relief organization. That modeled member's practice may vary depending on their surroundings. Informed collegial care for patients with endocrine problems as a part of a broader practice of general surgery that includes emergency call duty and whatever other services are valuable in their community. Practice patterns vary by setting. In a metropolitan area, practices may be highly specialized. It may not be possible to have a broader practice than that. On the other hand, practices in smaller communities may be broad, and practices in rural communities may extend beyond general surgery, particularly to include parts of obstetrics, gynecology, and orthopedics. I think the role of the AAES should be to support all surgeons who practice endocrine surgery in these settings in a highly effective level, because endocrine surgery is practiced in all of those settings, and our patients deserve it. I better not skip a page. You may recognize this slide from yesterday. Alan Sipperstein's group presented a very fascinating paper about the access to high-volume surgeons across the country and the number of high-volume surgeons there are in a variety of different states adjusted per million population. Their conclusion was that we should increase access to high-volume surgeons, and I agree with Alan and his colleagues. However, we should also do other things. We should improve the practice level of the low-volume surgeons. An alternative reading of this map might say that there are regional characteristics, including population density, not just population size, geographic or economic barriers to people moving around to get care, that might prevent consolidation of these cases into high-volume centers and might make the only way to improve the level of care improve in those people who do fewer of these cases. Most of the endocrine surgery that we do is actually relatively low-intensity treatment, and the facilities to do this exist in almost every setting. And so we should ensure that the people who are there in those facilities can do it in the best possible way. To do this, I think our AAES educational programs, including the annual meeting, and our QI programs, including CSQIP, should be really emphasized to deliver support for people who are in those situations. We should emphasize professional development efforts and the necessary continuing medical education for people to maintain a high quality practice for that archetypal member. In short, I think our society should be larger, not to provide more support for more specialists, but in fact to support more practitioners for whom endocrine surgery is only a part of their weekly work. To summarize, for the trainee, I recommend a residency in general surgery, either in the traditional model as shown here, or in one of the new models such as the flexibility and surgical training model, as long as that leads to general surgery certification. I think the optimal capstone to that is focused training in endocrine surgery to generate that highly skilled surgeon in that area, and I especially favor an endocrine surgery fellowship model that combines the transition to practice principles. For the Endocrine Surgery Training Program Director and the AAES Fellowship Accreditation Committee, I think that we should include the transition to practice principles as outlined by the American College of Surgeons in the Endocrine Surgery Fellowship as the best way to prepare our trainees for a long-term independent practice. For those of us who hire young surgeons, I think we should design positions that have the new recruit practicing broadly initially, as long as we also allow them to build focused experience and reputation in a subspecialty area as their career goes along. Finally, we need to provide mentorship during that early career years to complete the transition to practice. For the AAES, we should recognize and celebrate the surgeons whose practice includes more than just endocrine surgery and support them, maintaining their knowledge and skills in the field, because that is a surgeon who I believe should be best served by our society's goals. I think if we do these things, I believe that we'll provide the best preparation and support for that satisfying 35-year career in surgery for our members. So finally, I'd like to thank you all for both the opportunity to be the president this year and for your attention this morning. Appreciate it.